Hello, welcome to this presentation. My name is Julie Emerson. I'm a student at Excelsior University. This is a Quality Improvement Initiative presentation where we explore the answer to the question, can case management help to reduce heart failure readmissions? During this presentation, we will review the PICO question, discuss why heart failure readmissions are an issue, go over person-centered concepts, the practice setting, and the stakeholders involved. We will also look at the nurse's role and responsibility, the evidence, the significance, the description of the initiative, and look at the team a little bit more closely. We will review organizational change theory and look at the perspectives of the different members of the interprofessional team. We will review the implementation of the plan, the integration of health information technology, and the resources needed to implement the QI initiative. We will discuss the implications for nursing and healthcare, the culture of safety, evaluation, conclusion, reflection, and the references will be at the end. The PICO question for this Quality Improvement Initiative is, in patients with chronic heart failure, can case management interventions in the hospital setting compared to no case management interventions in the hospital setting reduce hospital readmissions by 15% over a 6-week period? Hospital readmissions seem to be an ever-present issue requiring case management attention. Of the chronic illnesses highlighted by Medicare to address, chronic heart failure is the most troublesome as it has the highest hospital readmission rates. The national average for heart failure patients' 30-day hospital readmissions is about 22%. Case management, specifically discharge planning, has been a strategy used to address length of stay and prevent hospital readmissions. Person-centered care is essential to case management effectiveness. Patient and family-centered interventions not only embody caring theory, but also demonstrate to patients and their loved ones what the essence of nursing is. Person-centered care involves an individualized treatment plan using evidence-based practice. Furthermore, person-centered care protects the patient's human dignity, actively partners with patients and families via shared decision-making, elicits improved patient engagement, and is ultimately a collaborative process. Caring behaviors centered on patients and families involve respecting a person's beliefs and values and working within the framework of their culture or perspective. When patients and their families' healthcare goals and culture are respected, the nurse case manager has honored the human dignity of the patient and family being cared for. In fact, according to Leininger, being cared for by a nurse is more important than being cured of illness. Patients say they feel seen and heard when their most pressing needs are met, such as food, shelter, and safety. Once patients feel they are cared for by nurse case managers, they make more efforts to engage in the healthcare system and learn how to self-manage illness. When a patient has engaged with the healthcare system, the patient is then ready to begin the process of learning how to self-manage their chronic illness. It has been my experience in nurse case management practice that patients report feeling valued after the nurse case manager takes the time to provide them with information and education to contextualize the data provided. Information sharing is another way to bestow human dignity to the patient by acknowledging that the patient is a person who is an autonomous being with the inherent right to participate or not as they choose. One of the goals of hospital case management is to encourage the patient and family to participate in the discharge plan. For community case management, the goal is for the patient to be able to self-manage their medical condition in the home setting. While patient and family participation is the most desired outcome, patients and families have the right to refuse to participate and to refuse assistance. This can be extremely off-putting to case management staff who are earnestly trying to provide patient assistance. However, for patients to use their full autonomy as human beings, it must be acknowledged that they have the right to refuse assistance as well as to accept it. It is critical for the nurse case manager to invite interdisciplinary team members and stakeholders to be involved in challenging patient and family care and dynamics. Each discipline and stakeholder has a unique perspective that provides insight and depth to the patient's healthcare needs. One of the most important ways interdisciplinary teams come together to address patient and family concerns is via our daily multidisciplinary team meetings, or MDRs. Collaborative care is devoted especially to addressing the patient's and family's needs and helps keep team members focused on moving the patient toward a successful hospital discharge. The practice setting for this QI initiative is a 385-bed Level 2 hospital in Ocala, Florida, called Advent Health Ocala. Currently, the hospital's heart failure readmission rate is 19.51%. Heart failure patients have some of the highest readmission rates within 30 days, potentially reaching as high as 25%. According to Khan et al., the national average for all-cause hospital readmissions is approximately 19.9% for patients with heart failure. The Centers for Medicare and Medicaid Services has enacted the Hospital Readmission and Reduction Program, which lowers avoidable readmissions through a reduction in payment. Hospitals, therefore, have a significant financial incentive to reduce readmissions. Although the hospital's heart failure readmission rate is below the national average, the goal is to reduce it further. The key stakeholders for this project include heart failure patients who have been readmitted to the hospital, the hospital's case management department, the hospital's heart failure coordinator, the hospital's quality and risk department, hospital attending physicians, and cardiologists who see patients both in and out of the hospital. Each stakeholder has a unique perspective on heart failure readmissions and is affected by this issue. While there may be other stakeholders related to this project, these stakeholders have been chosen because they are the most affected. Heart failure patients who have been readmitted to the hospital. These are patients who are chronically ill and are the focus of the QI initiative. If the QI case management interventions are effective, heart failure patients should experience an improvement in their health and/or quality of life. Ideally, there will be fewer trips to the hospital and more time spent at home. Hospital Case Management Department. The Hospital Case Management Department will be responsible for performing the QI interventions. Case managers will need to engage in discussions during multidisciplinary team meetings and follow up with staff and patients to complete the interventions. Case managers will not be responsible for the clinical aspects of the discharge bundle. Still, they will be responsible for verifying whether the physician and nurse have reviewed the evidence-based heart failure medication guidelines and whether the patients are taking the recommended medications. The in-hospital interventions will enable case managers to manage the case effectively. The discharge bundle will ensure that case managers address evidence-based discharge planning interventions. Hospital Heart Failure Coordinator. The Heart Failure Coordinator provided evidence-based guidelines for the discharge bundle. The Heart Failure Coordinator is already performing bedside education to patients. The Heart Failure Coordinator gave valuable information about the barriers to heart failure patient care after discharge. Two of the biggest concerns stated are patient noncompliance with a cardiac diet and lack of available cardiology follow-up appointments. Before the QI initiative begins, the QI initiative project coordinator will verify that documentation of this education is available for case management to confirm that it has been completed. Hospital Quality Risk Department. The Quality and Risk Department will conduct bi-weekly multidisciplinary heart failure readmission case study reviews to review what has gone well and identify areas that need improvement, aiming to prevent future readmissions. The Quality and Risk Department oversees readmission data. Additionally, the Quality and Risk Department has hired a nurse practitioner to interface with patients and staff in the emergency department to prevent unnecessary readmissions. Hospital Attending Physicians. The attending physician is the manager of the patient's medical plan of care during a hospital stay. The attending physician can interface with cardiologists who are being consulted to ensure that the evidence-based heart failure guidelines are being addressed during the hospitalization. Furthermore, the hospitalist is the key figure who will order the discharge treatments. Unfortunately, the hospitalists are a contracted group and are unable to provide follow-up visits. Cardiologists. Cardiologists are the key providers for managing patients' heart failure symptoms, both in and out of the hospital. Unfortunately, according to the Heart Failure Coordinator, the cardiologists have been reluctant so far to implement the heart failure bundle recommended by the American Heart Association. Additionally, patients are reporting that they are unable to get in to see the cardiologist before their symptoms worsen to the point of requiring immediate attention in the emergency room. The reality is that until more cardiologists come into the area to open practices and increase cardiology follow-up availability for patients in the community, the hospital's multidisciplinary team will continue to try to find solutions to address patients' outpatient heart failure needs. The professional nurse plays a leadership role in addressing quality improvement initiatives and enhancing hospital processes and patient outcomes. Nurses traditionally run multidisciplinary team meetings, interfacing with different disciplines to promote patient well-being. Nurses have traditionally been at the forefront of improving organizational processes to enhance patient outcomes. Nurses are responsible for improving and initiating patient sanitary conditions, creating public health initiatives, and treating the underserved. The Quality and Risk Manager, who oversees all quality improvement initiatives, is a registered nurse. The Heart Failure Coordinator is a registered nurse. The Case Manager facilitating the Quality Improvement Initiative is a registered nurse. Registered nurses have the most experience with direct patient care as well as the management of patient care. According to Orton et al., quality of care in any setting is not possible without nursing. However, case management effectiveness at preventing readmissions has had mixed reviews. While some studies support the use of hospital case management as a tool to prevent CHF readmissions, there are very few clearly defined interventions for case managers to latch onto or duplicate. A quality improvement initiative testing the validity of the claim that case management can reduce CHF hospital readmissions via a discharge bundle incorporating best practice guidelines offers a way to replicate specific case management interventions to determine their effectiveness for local community members. There are several pressing reasons CHF hospital readmissions should be addressed. One of the most important reasons is because the higher a hospital's readmission rate is, the lower the quality of care received at the same facility. The second reason is because CHF hospital readmissions are costly. Readmissions due to CHF are expected to exceed $70 billion by 2030. And the third reason is because hospital readmissions due to CHF are preventable. This QI initiative is an investigation to determine if case management interventions can reduce heart failure readmissions. According to Lindsay and Welch, case management can reduce heart failure readmissions by implementing a discharge bundle. After speaking with the interdisciplinary team, several interventions have been identified that will comprise the discharge bundle. Case management will begin discussing the elements of the discharge bundle during daily multidisciplinary team meetings. Two different treatment locations will be addressed. First, the current hospital admission treatments will be discussed. Afterwards, the discharge plan will be discussed. Inpatient interventions to discuss during MDR to pace the case. Case management will consult with the attending physician and nursing staff to determine if the patient has been prescribed the evidence-based recommended medications provided by the heart failure coordinator. If not, case management will also ask the physician and nursing staff to verify whether the reason for the medication contraindication has been documented. Next, case management will ensure that heart failure education has been completed. Case management will ensure that a nutrition consult has been ordered. Discharge planning interventions to discuss at MDR and follow-up. Case management will discuss whether either cardiac rehabilitation or home health is appropriate after discharge. Case management will provide a follow-up appointment with the cardiologist within 7 days of discharge. If a timely appointment is not available, telehealth or other alternatives such as dispatch health, community paramedicine, or a referral to nurse navigator will be explored to ensure that the patient receives timely care. If the patient is insured, case management will verify that the patient has transportation to the pharmacy to pick up prescribed medications upon discharge. If the patient is uninsured, case management will explore whether discounted medicines can be obtained through the hospital pharmacy's Meds to Bed program. The QI Initiative team is as follows. Myself, the QI Initiative Coordinator. The Case Management Leadership, which consists of 3 members who lead the Case Management Department. The Care 360 Leader, who leads the department that schedules patient follow-up appointments and works closely with case management. The Hospitalist Leader, who leads the hospitalist group that case management staff meet with during MDRs. The Heart Failure Coordinator, who provided key information related to heart failure readmissions and was approached the most when coming up with interventions that would complement what is already being done. The Risk and Quality Director, who is head over all readmissions prevention initiatives and supervises the Heart Failure Coordinator. While many of the interdisciplinary team for the QI project were positive about the idea of a QI project, the actual process of implementing the interventions outlined in the project may encounter some level of pushback. For example, when this writer initially approached the heart failure coordinator, he did not want to provide any information that would facilitate concrete interventions that case management could implement to support his efforts to prevent readmissions. However, when this writer assured him that the goal was not to invalidate his work, but rather to complement and support his efforts, the heart failure coordinator became more supportive and suggested a discharge bundle, which this writer had also found in evidence-based literature. To address change, elements of Cotter's 8-stage process for organizational change were incorporated. In the example previously mentioned, the first 4 stages of Cotter's model were briefly presented, as seen with the heart failure coordinator. The result induced cooperation and teamwork. Cotter's model proved indispensable because the information from the heart failure coordinator regarding this project has been the most valuable, as predicted by all other interdisciplinary teammates. Cotter's 8 stages are as follows: establishing a sense of urgency, creating the guiding coalition, developing a vision and strategy, communicating the change vision, empowering employees for broad-based action, generating short-term wins, consolidating gains and producing more change, and anchoring new approaches in the culture. These 8 stages are easy to understand and implement for the leader who wants to effect positive change in their organization. The QI initiative process is a team project. Without the input of key interdisciplinary team members, the project is doomed to fail. However, if team input is incorporated into the project, the team will have buy-in and be more likely to back the project. While QI projects are necessary, they involve change and disrupting the order of how things have always been done. Cotter's 8-stage process for organizational change provides the QI initiative team leader with a working model to move the project forward and to overcome pushback. The case management director in our hospital is a social worker. The case management director suggested that a QI initiative addressing readmissions should begin with heart failure patients, as they have traditionally had the highest readmission rate at our hospital. The case management director will ultimately be responsible for overseeing the implementation of the QI project. She will be required to provide personnel for the project and to provide some level of training on how to perform the new interventions. She will have to juggle the QI initiative with other administrative directives she has been given by corporate superiors. If she feels the case management QI initiative is cumbersome or will create too much difficulty for her staff, the case management director may not approve the project despite its potential benefits. The hospitalist leader is an internal medicine trained physician. He is responsible for leading the hospitalist contracted internal medicine group that participates in daily multidisciplinary rounds, MDRs, with case management, registered nurses, and physical therapists. Case management collaborates closely with the hospitalist group to stay informed about patients' needs during their hospitalization and to anticipate their needs for discharge planning. Hospitalists can address needs presented during hospitalization, but are unable to follow up once a patient has been discharged to another level of care. Some of the concerns reported by the hospitalist leader include patient noncompliance with necessary diet and lifestyle changes at home, and a lack of timely follow-up appointments with community cardiologists. The heart failure coordinator is a registered nurse who has specialized in heart failure education and is the most knowledgeable team member regarding evidence-based best practice interventions for heart failure patients as outlined by the American Heart Association. The lack of cardiologist participation in implementing the American Heart Association's evidence-based guidelines during hospitalization was discussed. The heart failure coordinator also expressed concerns that patients are not retaining the heart failure education provided during their hospitalization, a finding supported by evidence-based research. Furthermore, there were concerns about patients with heart failure being resistant to recommended diet and lifestyle changes. The lack of cardiology follow-up visit availability was felt to contribute to readmissions, as heart failure patients have been instructed to go to the hospital emergency department when cardiologists are unable to provide an office visit. The Quality and Risk Director, a registered nurse, has been tasked with overseeing the reduction of all hospital readmissions. The Quality and Risk Director was very interested in the proposed QI initiative to see if the interventions work. She states she has also hired a nurse practitioner for the emergency department to help prevent medically unnecessary admissions. She also expressed a desire to implement biweekly MDR-style heart failure readmission case studies that will review both positive interventions and missed opportunities that transpired during a patient's stay. The QI interventions proposed are based upon the premise by Lindsay and Welch and incorporate best practice inpatient interventions and discharge planning interventions that can be discussed during multidisciplinary rounds, MDRs, and followed up afterwards by case management staff. The QI project is expected to last 6 weeks. Each week, the QI project coordinator will meet with the case management staff involved in the project to gather feedback and address any issues that may arise. In our current hospital practice, all admitted inpatients are expected to receive an evaluation by the case manager that addresses social determinants of health and whether their basic needs are met at home before hospital admission. However, both inpatient and discharge planning interventions were identified to assist heart failure patients specifically. These interventions can be conducted mainly during MDR meetings with minimal follow-up required from case management afterwards. In addition to physician review for history of heart failure, identification of heart failure patients will be made through the electronic medical records program and through the risk management daily readmissions reports. Several resources will be used to facilitate the implementation of the QI project. The first resource will be a checklist provided to the case manager to use during MDR, ensuring that inpatient and discharge planning items are addressed. As a courtesy, the checklist will also be provided to the attending hospitalist and nursing staff so that they can understand what case management will review for identified heart failure patients during the MDR meeting. Second, we will heavily utilize the electronic medical records program to identify patients as well as to cross-check high-risk readmissions from the risk department's readmission list and the heart failure coordinator's readmission list. Initially, it was thought that we would attempt to provide scales and blood pressure cuffs to heart failure patients, as our hospital previously had a resource that could offer this service. However, that resource has gone virtual, so we decided to forego that intervention from a case management standpoint. It was felt by case management leadership that if those items are needed, the heart failure coordinator can follow up with the virtual resource to make the necessary arrangements. There are no additional costs identified for implementing this QI initiative, as readmissions are already being determined by the electronic medical record, EMR, and other information programs used by the risk management department. Furthermore, a checklist provided to case management and MDR staff is minimal and can be completed virtually via email. It is only required in print for those with a personal preference. The most important resource required would be making the time to address the discharge bundle interventions. This would involve the case management leadership assisting in identifying heart failure patients for the QI intervention, as well as the case management staff member addressing the interventions. However, once a process for identifying heart failure patient becomes routine, the time required for this step is expected to diminish. The same is true for the case management interventions. The more often they are implemented and become habit, the less time it will take to complete the process. Several implications for nursing practice will arise from this QI project. The first is that additional evidence-based information on heart failure readmissions from a case management standpoint will be gained, whether the QI project succeeds or fails. Should the QI project succeed, case managers will have a new protocol for addressing heart failure readmissions, and other hospitals may potentially expect case management to address heart failure readmissions in the same manner in the future. In daily practice, new case management leadership would need to be trained on how to identify heart failure patients early through EMR and other information programs currently used. Additionally, case management staff and MDR staff must be aware that heart failure patients require a specific set of case management interventions related to their disease process and be trained on how to implement these particular interventions. Lastly, suppose the QI project is successful and demonstrates that heart failure patients require specific evidence-based case management interventions to prevent hospital readmissions. In that case, this concept may also apply to other core diagnoses, such as chronic obstructive pulmonary disease, acute myocardial infarction, and diabetes. This QI project has the potential to lay the groundwork for addressing other patient populations who are frequently readmitted to the hospital. A culture of safety in a healthcare organization begins with leadership. According to the National Steering Committee for Patient Safety, an organization's culture of safety is formed when the leadership values safety. The National Steering Committee for Patient Safety makes 4 recommendations for leaders to promote safety in their organizations. 1. To ensure safety is a demonstrated core value. 2. To assess capabilities and commit resources to advance safety. 3. Widely share information about safety to promote transparency. And 4. To implement competency-based governance and leadership. Healthcare organizations uphold safety as a core value through leadership example. One of the ways that leaders model safety is by ensuring that not only the patients but also staff are safe both physically and mentally. Another way leaders demonstrate their commitment to safety is by incorporating safety into leadership meetings, allocating time at each meeting to discuss safety. The implementation of mandatory competencies ensures that the entire workforce has the necessary skills to provide safe care. Safety standards have value when leaders address systemic safety concerns. Transparency in reporting safety-related incidents as well as lessons learned to reduce harm enables others, both inside and outside the healthcare organization, to see core safety values lived out. Nurse leaders have a responsibility to model safety and to create a safe environment for patients and staff. When nurse leaders are actively engaged in ongoing skills development, best practice guidelines reviews, and competency assessments, a culture of safety and accountability begins to emerge. Nurse leaders must lead from the front, holding themselves accountable along with their staff to ensure safety is valued at every level. At this time, the QI project is still in the planning phase and was scheduled to start on July 15, 2025. The QI initiative will be evaluated through quantitative measurements via a numeric value. The metric tool currently used to document the number of heart failure readmissions will also be used to assess whether the ratio or percentage of heart failure readmissions has increased or decreased. The heart failure readmission rate is a meaningful and easily identifiable measurement that can be used to assess the success or failure of this QI project. Currently, our hospital heart failure coordinator reports a readmission rate of approximately 19.51%. Among the heart failure patients identified for this QI initiative to receive case management interventions, the percentage of these same patients who readmit to the hospital will determine the success or failure of the initiative. A stagnation or an increase in this specifically identified population group as identified for the QI initiative means that if this group either equals or exceeds a readmission rate of 19.51%, then the QI initiative will have been deemed a failure. Conversely, a decrease in the readmission rate for this population will demonstrate the success of the QI initiative. The goal is to reduce heart failure readmissions by 15%, which is approximately 2.93%, or about 3%. Therefore, if the readmission rate for the selected group of heart failure patients participating in the QI initiative is reduced to approximately 16.58%, then the QI initiative will be deemed a success and have achieved its purpose. At the end of the QI project, I plan to conduct either a group discussion or a questionnaire to review both the positive and negative aspects of implementing the QI interventions for each interdisciplinary team member who participated. This feedback will identify the positive elements involved in performing the interventions, the barriers to implementation, and suggestions for improvement. There is currently no plan to conduct a patient or family survey. The process of creating a QI initiative has been enlightening. It has opened a window into what it means to be a nurse leader and to be accountable to improve faulty organizational processes. While many disciplines are involved in QI initiatives, nurses are the primary drivers of quality improvement in healthcare. Nurses are in unique positions to affect change in many different areas of healthcare. Every discipline has value, and each discipline's role is unique. However, it is nursing that establishes the culture in a healthcare organization. It is nursing that often identifies patient safety concerns and brings the team together to develop solutions to address those concerns. This concludes the presentation. Thank you so much for watching.